District Chief Jason Evans here with you, and today we're going to be discussing diabetic emergencies. As you know, the world of pre-hospital emergency medicine is always evolving, and it's very important that we here at Manatee County EMS continue to evolve right along with it. There's always new treatments, new protocols, new medications out there that might be better for our patients. When it comes to our current treatment of hypoglycemic or our diabetic patients, D50 is the medication of choice. Well, 25 grams of D50 all at once into a diabetic patient's bloodstream might not be the best approach for them. When we give the D50, we see a rapid spike in the patient's blood sugar. Now, it does reverse the side effects of the hypoglycemia, yes, so it does a great job at that. But when it comes to the health of a diabetic patient, it's those peaks and valleys within the blood glucose measurements that we want to stay away from. A nice consistent blood sugar level is definitely beneficial. So we're looking at D10. D10 might provide some of that consistency that we're looking for. Another reason that we're switching to D10 is that D50 is getting really hard to get. It's going to go on national back order here. So we have to be flexible and look at other options to treat our patients. So let's look at a few objectives for today. What a beautiful night. Oh, sorry, I was just admiring the city lights out there. It looks beautiful. So we're going to start out with a nice review of anatomy and physiology of the endocrine system. It's always good to brush up on that stuff. Then we're going to look at our treatment options for our hypoglycemic patients. We're going to have D50 until it runs out. Then we'll be going with D10. Then we'll have the new Transcend oral glucose for those hypoglycemic patients that are able to follow commands and swallow that appropriately. Then we'll have, of course, the glucagon. Next, we're going to review our protocol. So the adult and pediatric diabetic emergency protocol will differ from the altered mental status protocol. And we'll review all those very nicely. And we're also going to talk about this phenomenal device right here, the Biberon Infusion Space IV pump. When it comes to our hyperglycemic patients, fluid administration is the mainstay of treatment for that subset of patients. So we want to make sure we're getting the accurate amounts of fluid on board these patients, and the best way to do so is via the pump. So hang on, folks, 'cause here we go. Okay, to get you guys squared away on the A&P portion of the training here, I'm going to use my best depictionary skills here to try to convey my point. So, in diabetes mellitus, your body has trouble moving glucose, which is a type of sugar. After we consume a meal, food enters the stomach. So we got the food, coming down, and it enters the stomach. And our food is made up of three basic ingredients. There are others, of course, but for the purposes of this video, we're going to focus on only a few. And they are carbs, fats, and proteins. During digestion, the carbohydrates that we consume are broken down into sugars, or glucose. These sugars are absorbed into the bloodstream and transported to cells within the body, such as our muscle cells, and within our adipose tissue, we have fat cells. In diabetes mellitus, your body has trouble moving that glucose into the cells. Your cells need that glucose as a form of energy, so that lack of glucose essentially starves your cells. Your body utilizes two hormones to get that glucose into your cell, and those hormones are insulin and, what's the other one? You got it, glucagon. Very simply put, insulin is used to reduce blood glucose levels, where glucagon is used to increase blood glucose levels. So insulin helps mediate the transport of the glucose into the cell, where glucose just does just the opposite. It increases blood glucose levels. So both insulin and glucagon are created by clusters of cells within the pancreas called islets of Langerhans. These clusters of cells within the pancreas have another subset of cells within them that creates the actual hormones. Insulin is created by the beta cells within the islets of Langerhans, and the glucagon is created by the alpha cells, which are in the periphery of the islets of Langerhans. And then your pancreas secretes these hormones as the body needs them. Glucagon does exactly the opposite. What glucagon does is it gets the liver to generate new glucose molecules from the breakdown of glycogen. So through the breakdown of glycogen, we get the liver to create or reduce stores of glycogen into glucose, which is then mediated into the bloodstream. So that's what glucagon does. So insulin works by binding to insulin receptors on the cell membrane that are present on insulin-responsive tissues. When these receptors are activated, vesicles containing glucose transporters fuse with the cell membrane, allowing the glucose to enter the cell. So let's look at that. So let's pick a good color for this here. Blue is always good. So as the pancreas excretes the hormone insulin, right? The hormone insulin enters the bloodstream. The insulin then connects to these insulin receptors on the cell membrane. So let's get this color here. So here's the insulin that binds to the insulin receptors on the cell membrane. And this enacts a process within the cell. What becomes activated are these vesicles within the cell. They're known as the glucose transporters. So here they are here, glucose transporters. These transporters then fuse with the cell membrane. Come out over here and they fuse with the cell membrane. It looks kind of like this. So once these transporters fuse with the cell membrane, it allows the glucose to then enter the cell. So insulin does a very good job of feeding our cells the glucose that it needs. So that's kind of how that whole thing works. Diabetes mellitus is diagnosed when blood glucose levels get too high, so we get too much glucose within the bloodstream. This is also called hyperglycemia. There are two main types of diabetes, and the main difference is the mechanism that causes the high blood sugar or the hyperglycemia. So in type 1, the pancreas doesn't produce any insulin. And then in type 2, the pancreas doesn't produce enough insulin, or the insulin cannot be processed. We get what we call insulin resistance. In type 1 diabetes, the body doesn't make enough or any insulin. It can happen via a genetic abnormality where the body's own T cells. So let's draw a T cell. This isn't an accurate description of a T cell here, but the T cells, what happens through this genetic abnormality is they attack the beta cells in the islets of Langerhans. And if you remember, within the beta cells, they produce the hormone insulin. So if we get our T cells attacking these beta cells that produce all our wonderful insulin, the hormone that allows the glucose into the cells, then if we lose these cells, then we lose the ability to produce insulin. Hence, we have type 1 diabetes. This destruction usually happens fairly early in life, hence the term juvenile diabetes. So there are some symptoms of diabetes mellitus that we need to be aware of. They are polyphagia, glycosuria, polyuria, and polydipsia. So let's chat about these.
So in diabetes mellitus, even though there's a lot of glucose in the blood, the glucose can't get to the cells where it needs to be. Remember, because that we have the absence of the insulin, which helps the glucose get into the cell. So we get a couple processes that happen secondary to this. Our muscle cells start breaking down protein. And our adipose tissue starts breaking down fat in a process called lipolysis. And this kind of sets off another process within the subject. It creates a lot of hunger. It causes them to be very hungry or have excessive hunger. So that's where that term polyphagia comes in. So let's draw a nice hungry person here. There we go, to represent the polyphagia. With high glucose levels in the blood that gets filtered through the kidneys, some of this glucose spills into the urine. Let's draw some of our glucose molecules here in the urine. This is known as glycosuria. And glucose is what we call an osmotically active substance. And this means that water follows it. So what this causes is an excess in urination. So we get a lot of urination. This is called polyuria. With so much urination, this causes dehydration, which in turn causes excessive thirst. We call this polydipsia. All right, so I think we've covered some of the main symptoms associated with diabetes mellitus. So within type 1 diabetes, we know that the pancreas no longer produces insulin. But this does not mean that within the type 1 diabetic that they don't respond to insulin. Insulin is still a very essential hormone to carry out all their bodily processes. So we still need to get the insulin into the bloodstream. So the insulin can attach to these insulin receptors, which in turn makes the cell membrane permeable, so these glucose transporters can allow the glucose to be transferred into the cell. So the insulin has to get into the bloodstream by different means. This is accomplished by insulin injection, or some folks with type 1 diabetes choose to wear an insulin pump. What's important in the health of the diabetic patient is to maintain that consistency between the injections of the insulin and their diet. Because we know that if they take too much insulin relative to the amount of glucose in their bloodstream, it's going to cause their blood sugar levels to drop too low, resulting in what we frequently see in the pre-hospital side as hypoglycemia. So we arrive on scene, we establish IV access, and we give either glucose in the form of, it's dextrose, what we give, another form of sugar. We give it in the form of D50 or D10. If we can't establish IV access, then we utilize glucagon. And you guys learned earlier about the hormone glucagon and what that does in the body. Now let's take a peek at hyperglycemia and a more specific condition that results from it called diabetic ketoacidosis, or DKA. Now, to completely understand DKA, we have to remember what we talked about earlier, which was lipolysis. And this was where fats are broken down into fatty acids. Now, the liver can utilize these fatty acids and convert them into what we call ketone bodies. Now, there's a benefit to these ketone bodies, and that benefit is that in the absence of glucose, our cells can utilize these ketone bodies for energy. The downfall of this conversion of fatty acids into ketone bodies is they make the blood extremely acidic. We typically see blood pH levels of around 7.3 or lower. Remember, normal range is 7.35 to 7.45. Remember that from paramedic school. And we typically see plasma glucose concentrations of around 250. So around this area, we might start to see some signs and symptoms of DKA. We also get a shift of hydrogen ions inside the cell. The shift of hydrogen ions inside the cell causes potassium to move out of the cell into the bloodstream. So we get an increase of potassium in the blood. This is called hyperkalemia. And anyone that's taken my 12-lead class knows all the possible cardiac implications of hyperkalemia. So as well as fluid administration, you should do a 12-lead on these patients to see if there's any cardiac involvement. So even if a diabetic patient is taking their insulin as prescribed, DKA can still rear its ugly head. An example of that would be stress in the body, such as an infection. And our little virus here doesn't look mean enough. I'm gonna make them look really mean. That's why you scare these red blood cells here. All right, so an example of the stress in the body would be an infection. In response to these stresses in the body, such as an infection, the body releases epinephrine. This epinephrine in turn causes a release of glucagon. And in the diabetic patient, this is not beneficial. And to those with a normal functioning pancreas, it wouldn't be that big of a deal because the glucagon would give our body the extra energy it needs to fight the infection. But in a diabetic patient, this is not beneficial because it's going to interfere with that hormonal balance that we have within the bloodstream of glucagon and insulin. And then once we interfere with that nice normal balance that we have of insulin and glucagon in the bloodstream, then that's going to lead to an excess of glucose in the bloodstream, because that excess of glucagon is going to cause the liver to do what it does with glucagon, and that's going to release those stores of glycogen, convert it into glucose, and then we're going to have an excess of glucose in the bloodstream. So these stresses in the body of a diabetic can lead to DKA. Another interesting thing about those ketone bodies that are produced by the liver and further utilized as energy is they further get broken down into acetone. This acetone escapes via the lungs when the DKA patient exhales, and it gives them that acetone smell to their breath, or that really fruity kind of chemically smell. A lot of people say that it smells like juicy fruit gum. And if you ever smelled it, I mean, I think it does too. Some other side effects of DKA that we haven't discussed are nausea, vomiting, altered level of consciousness, and cerebral edema. The mainstay of treatment pre-hospital is going to be fluid administration, which Chief Dwyer is going to go over later when we discuss protocols. In the hospital setting, other treatment will include insulin and electrolyte replacement to try to combat the acidosis. Now let's take a few minutes here to discuss type 2 diabetes. If you remember type 1 diabetes, we have a condition in which the body's T cells eliminated valuable beta cells within the islets of Langerhans, eliminating the pancreas' ability to produce insulin. In type 2 diabetes, we have a functioning pancreas that has either an inability to produce sufficient amounts of the hormone insulin, or we have a condition present called insulin resistance. So in type 2 diabetes, we still have the islets of Langerhans. So they are still here and they are still functioning. And they are producing the hormones insulin and glucose respectively. But there's a couple other factors. Either these cells are not producing enough of the hormones to properly regulate blood sugar, or somewhere else in the body we have a condition called insulin resistance. Let's chat about that. So in type 2 diabetes, the pancreas is still making insulin, but the body doesn't respond to it. So the pancreas is still excreting the hormone insulin into the bloodstream. The bloodstream then passes the insulin onto the insulin receptor. So even though the insulin is attaching to the insulin receptor, and in the normal healthy body, once the insulin attaches to that insulin receptor, it makes the cell wall permeable and allows the glucose transporters to attach to the cell membrane, thus allowing glucose to enter into the cell. But even though the insulin is attaching to the insulin receptor, this process still is not happening. The glucose is not getting into the cell, and that's called insulin resistance. Some risk factors for insulin resistance are hypertension, obesity, lack of exercise, and some people are just predisposed. There are genetic factors that can cause the condition. So what's happening in type 2 diabetes is the pancreas and the islets of Langerhans are, to try to compensate for this resistance, are producing more and more and more insulin to try to get these receptors to finally, open up so the glucose can get in and do its trick. So the pancreas is really, really working overtime to try to combat this insulin resistance that's going on, so we can try to get the glucose out of the bloodstream and into the cells where it belongs. This increase in insulin production happens as a result of that resistance. And what we can get within the pancreas is the pancreas is just working overtime, and it's really causing some unwanted effects. We get what we call the beta cell hyperplasia, which means we get an increase in the amount of beta cells that are in the pancreas. And then we can also get beta cell hypertrophy, which is the size of the beta cells themselves. They just become very big and hypertrophic as it tries to keep up with the demand of the insulin production that's needed because of the resistance in the body. And unfortunately, after time, what happens is we get all this hyperplasia, and then we get the hypertrophy. Is the cells they start to become dysfunctional, and then they die. They cease to function altogether, which is very unfortunate. And then we get a decrease in the amount of beta cells that are even functioning at all in the pancreas. So we get a very sparse and very diminished output of insulin secondary to that. And we all know what that leads to: the dreaded hyperglycemia. There are a few other causes of diabetes mellitus that we have not yet mentioned, and I want you to be aware of them. They are gestational diabetes, which can sometimes present in pregnant females during their third trimester. And then there's drug-induced diabetes, where the side effects of certain medications can cause alterations in blood glucose. All right, folks, that's going to wrap it up for the A&P portion of the training. I hope you found it informative. I hope you learned something. I hope you take something away with you. I hope that when you're out there treating your diabetic patients, your hypoglycemic patients, or if you have patients that present in DKA, you'll have a little better insight in how to treat them. So as always, thank you for everything that you do, and take care.
All right, so you'll notice there's a nice ambulance over here. Jason let me be in a video. It's weird. It's weird. All right, so as District Chief Evans was kind of talking to you all about, and what we're trying to do is we're trying to change a little bit of our treatments with diabetics. Diabetics, for a couple of reasons, we're changing. One, back orders, and two, we don't want to create peaks and valleys in these diabetic patients anymore. So the first protocol we're going to touch on is the adult altered mental status protocol. The changes I want you to kind of key in on when you're doing your studying is the fact that we're now going to separate out diabetic patients. So if you notice, you're looking on the right side of the protocol, which is here. Can't see it, but you guys can. It's here. You'll see that the diabetic part is kind of moved out. The other part I want you to look at is before you even start looking at treating a diabetic is our parameters have changed a little bit. So before we had less than 65, we're moving that down to less than 60. And I'll tell you why a little bit later. Bear with me a little bit. Also, you'll notice is there's 300 on there. So blood sugar is above 300, we're actually going to start treating. Not that we haven't before, but we're going to give you some guidelines now to hopefully help treat our patients a little bit more appropriately. Down the suspected drug involvement on the distant side of the protocol, on the left side of the protocol if you're reading it, we wanted to incorporate the memos that we've been sending out. We've had issues with opioids in the past, and we want to kind of titrate the amount of Narcan we were giving. So that hasn't changed. Post memo, all we're doing now is we're putting it in front of you so you can see we're doing 1 to 2 milligrams up to 6 milligrams wire with the patient. Important note though, you'll see now it's going to be required that we monitor our patients with capnography. Why? Well, how else are we going to manage their airway or decide how we manage their airway but with capnography? Breath by breath, we see what's going on. All right, so we didn't want to leave the kids out. We made a pediatric altered mental status protocol, or we updated it. You'll notice, as we go down this protocol, we've kind of got a little bit of some changes. So this is why we're here. We're going to talk about those changes. First change you're going to notice is, again, much like the adult, we have a new number of 60, less than 60 for our pediatric patients that are symptomatic. We're going to look to start treating them. Neonates, less than 40, we're going to look to start treating them. We'll talk about that a little bit later. And again, above 300, we're going to look to start treating those patients that are hyperglycemic. Once we've determined one of those things have been met, we'll go over to the green side of the protocol here, where it directs us to go to the diabetic emergencies. This one's specific to diabetic pediatric emergencies. We'll go to that protocol, which we're going to cover in a little bit. What you'll also notice in this updated protocol is on the far side of the protocol, you'll see suspected drug involvement. This hasn't changed. This is still reflective of the old protocol. But to provide some clarity and to reinforce some things we've been talking about, we're still going to manage their airway, BVM, OPA, NPA, whatever is appropriate. But we're also going to start giving Narcan. So our dose for Narcan is 0.1 milligrams per kilogram, IV, P, or IN. And we can repeat that up to 3 times, not to exceed 6 milligram dose. So that's the pediatric altered mental status protocol. I didn't realize you had it going. All right, so diabetic emergencies for the adult patient. You'll notice, like we discussed earlier, this is a different protocol. So we separated it a bit. Important note, it's blue, it's not pink, so it means it's the adult patient. We're still going to assess our patients. We're going to look for their medications, their histories, things like that. We're going to look for signs and symptoms with our diabetic patients. Are they pale, cool, clammy, or are they hot, dry? Kind of looking for indications of whether they're low blood sugar or high blood sugar, or maybe something else is going on. Universal patient care protocol is still there. We're going to assess the blood sugar. We do that on most of our patients, but for sure we're going to do it on those that we suspect there may be a problem with their blood sugar. If it's high, above 300, we've now got a protocol specific for these patients. So what do we want you to do? Well, we want you to treat it with some fluid. We need to wash out all the bad stuff that's going on. Earlier we talked a little bit about anatomy and physiology, or maybe later in the video, but you'll notice it'll be discussed later on what's going on. But we need to give these patients fluid. We need to give them a lot of fluid. So our first fluid amount we're going to give these patients is 500 cc's of fluid. That's going to be a bolus of fluid. After that's completed, we're going to start 1 liter per hour fluid administration on these patients. It's important that these patients are above 300 on their blood sugar. They may be unconscious. If they're unconscious, then we're going to be more aggressive with how we give that fluid. So maybe an IO may be pertinent for these type of patients or appropriate for these type of patients. Like I said before, first dose of fluid is going to be that 500 cc bolus. The second set, and what you guys can all see on there, is 1 liter an hour. How do I do in a liter an hour? There's a pump. I know there's a pump. For sure, Evans knows there's a pump because he talks to you guys about it enough, but use a pump. Well, how do I do that? Lucky for you, we're going to show you a little bit later. So don't worry about that. We'll get to it. So that's the hyperglycemic patient. Any other issues, you're going to contact medical control. You'll see the arrow kind of goes down, points to that. For our hypoglycemia patients, and again, the numbers change to 60 from 65 to 60, we're going to do things a little bit different. We're going to first assess their LOC, not that we haven't already, but we're going to look a little bit deeper into their LOC. And what we're looking for is we're looking for their ability to swallow. Their ability to swallow and also follow commands are two things that we're going to help us to delineate what treatment path we go down. So if you notice there, we have an oral glucose option. This is new for us. Before we give or provide any medication via PO, we need to make sure these patients can tolerate the PO medication. So oral glucose is a PO medication, hence the word oral. What we're looking for is their ability to swallow. So to do that, do a couple things to kind of verify in your mind that they're capable of doing that. Have them stick out their tongue, see if they can follow that direction. Have them stick out the tongue, move it from side to side, up and down. That's helpful. Look for or ask them to cough. Make sure that reflux isn't impeded in some way. If they can't do it, we're going to go a different route. And the last thing I'm going to have, or what we want you to do, is to put your hand on their throat and ask them to swallow. You should feel the musculature move up and down when they are swallowing. Again, that's helping you to verify that they indeed can take oral glucose. And if they do all those things, follow commands, able to move their tongue around, you notice that they can cough, you're feeling that the muscles are able to maneuver in a way that would indicate that they can swallow, then yes, they can have the oral glucose. The risk that we run into is if we give that to somebody that can't, we run the risk of aspiration, and we've kind of worsened a problem that's already not good since we're there. We're going to give 15 minutes on the oral glucose for it to work. We're going to reassess. If that doesn't work, you'll notice we'll swing into the administration of D25, D10, which we'll talk about here in a moment. If they are unconscious or can't do those things, we're going to go the route similar to what we've done before, which was IV medications of dextrose. If D50 is available, 25 grams IV is fine. But what we talked about earlier is it's becoming less available. So our next option, or another option we're going to have to pull, is the D10. D10 comes in a 250 bag, and we're going to give that over around 10 minutes. If we can't get an IV, and we've tried 3 times to get an IV, 1, 2, 3 times to get an IV, not ruling out jugulars for this type of thing. If we're going to go the route of glucagon, make sure you're looking at all your options. Then we can pull the trigger on IM glucagon. But we have to try 3 times. We can't just pull the trigger and say, okay, we're going to go ahead and give glucagon. That's not a thing. That's not the expectation of doc. So we want to try for an IV, and we're either going to give D50, 25 grams, or D10. And if we can't get an IV, then we're going to go the route of glucagon. We're going to reassess our patient after 10 minutes once we've decided to do one of those things we just discussed, and if needed, we can give a repeat dose of D10 or D20 or D10 or D50, 25 grams. What's also important to note is we've added a pearl at the bottom, and that pearl is to kind of be less aggressive a little bit with this medication. We touched on D10s not as of a potent medicine that we've been giving, so it's a little bit slower increase in their blood sugar as opposed to D50, but we can also titrate the amount we're giving of D50 or D10 based on the mentation increase on the patient. And what we're looking for in the mentation side is a return to their baseline normal is what we're looking for. Thiamin's still at the bottom down there. We can give that if it's pertinent for those ETOH or chronic ETOH patients. and chemo patients, and that's a 100 milligram dose. Now, just kidding. Pediatric diabetic emergencies. It's pink. Number 1, it's pink. Number 2, you'll notice a little bit of changes across the top. We're still going to assess our patients, but we're looking for, and what's going to change a little bit, is our treatment for neonate patients. So anyone or any patient 0 to 28 days, that's going to be a neonate patient for us. It's going to change a little bit, and you'll see why here in a second, so we need to know that information. Signs and symptoms, same as before. Cool, clammy skin, warm, dry skin. Universal patient care protocol is still there. We're going to look for the patients that are symptomatic, meeting the symptoms that are kind of outlined on that top right portion of the protocol. Low blood sugar, high blood sugar. Let's talk about high blood sugar first. Above 300, we have a protocol for it now, which is fantastic. We wanted to give you guys some direction, and here is that direction. We're going to start an IV. If critical enough, an IO is fine. Unconscious patients having, multitude of issues, you need to be somewhat aggressive with these patients, it's fine. Start an IO. Please start an IO if you can't get an IV. We're going to do a fluid bolus on these patients. 10 mLs per kilogram over 1 hour. You're going to ask yourselves, how do I do that? Evans is going to show you later. But we want to treat those patients that are hyperglycemic. So please make sure you're familiarizing yourself with the pump and use the pump a little bit more so you can practice in the back of your trucks or and you're not learning in the middle of a call, because the last thing you want to do is learn in the middle of a call. For our hypoglycemic patients, there's 2 numbers as far as what we constitute hypoglycemia. For our pediatric patients, above 0 to 28 days, anything less than 60 on our blood sugar, we're going to treat. For our neonates, we're looking for a blood sugar less than 40. Again, 0 to 28 days. We're going to again assess their ability to swallow, and we're going to assess their mentation level. We're looking for their ability to follow commands, stick out their tongue, cough. We can also again feel their throat to see if they can swallow. If they can do all those things, oral glucose is fine. It's the same dose as what we're doing for adults. It's going to be 15 grams, which ultimately right now is a whole tube. It's strawberry flavored. I hope they like it. I'm going to try it later. I'll let you know. For the patients that can't follow commands, can't swallow, then we need to go the route of starting an IV. We have on there the dose of D25. Hasn't changed. If it's an option, we want you to use that. So D25, we discuss how to make that with our D50. So we'll refresh you on PALS. If you need a refresher, get with your district chiefs. We'll get you the information. But D25, we want you to make that. And we're going to do a 0.5 gram per kilogram IV of that. If that's not the option, or if D10 is available, we're going to do D10. So D10 is 5 mLs per kilogram IV. If that's not an option, or if we can't get an IV, we have the glucagon option. Glucagon, if they're above 20 kilos, is 1 milligram. If they're below 20 kilograms, it's 0.5 milligrams. We're going to reassess our patient after 10 minutes. If we don't have what we need, if their mentation hasn't come up, or their blood sugar is still low, 60 for the pediatric, below 40 for the neonate, we're going to repeat our dose of dextrose, whether that's D25, 0.5 grams per kilogram, or whether that's the D10, 5 mLs per kilogram. At the bottom, we've added again, titrate. Please titrate to the baseline mentation of that patient. We don't need to be shooting these sugars up real high if we don't have to. Once we get their sugar up, we'll give them a little bit of food, assuming they can swallow and tolerate it, maybe some protein, so we can get their sugar kind of level off and maintain at a nice even keel for that patient. And that's pediatric emergencies, diabetic.
All right, let's get you guys squared away on the IV pump. That's a pretty cool background, huh? Want to see what's really cool about it? Watch this. Want to start her back up? How about that? Really neat. So, why are we using the IV pump? There's a couple good reasons why we're using it. First of all, let's take a peek at the protocol. So if we look at the adult diabetic emergency protocol, we can see on the right side of the algorithm, if we have a patient with a blood glucose measurement over 300 milligrams per deciliter, these patients are hyperglycemic, possible diabetic ketoacidosis. And if you remember, in ketoacidosis, what the issue is that glucose, the excess glucose, gets filtered through the kidneys. And since glucose is an osmotically active substance, water follows it, which causes that polyuria, which in turn causes severe dehydration. So it's very, very important that we get the fluid on board for these patients. So you can see the treatment for fluid is a 500 cc fluid bolus. We will not be doing that through the pump because the pump has a 1200 cc an hour max. It's not fast enough to keep up with that. So we need to get that initial 500 cc's on board very quickly. Then you can see we follow with that 1 liter per hour. So again, as good clinicians, we always want to prevent possible fluid overload. So that's given through the pump. It's a very accurate delivery so we don't fluid overload our patients. Look at the pediatric diabetic emergency protocol. Again, you can see on the right side of the algorithm there for blood glucose measurements over 300 milligrams per deciliter. Again, our hyperglycemic, possible diabetic ketoacidosis patients. We need to get that fluid on board. And for the pediatric patients, it's 10 mLs per kilogram, and that's given via the pump. So it's no longer a recommendation anymore. It's you will use the pump to treat these patients because it's in the protocol. We don't want to deviate from the protocol. So what are some other great reasons that we should use the pump? So like I've stressed and mentioned many times already, the fluid overload issue, right? We never want to fluid overload our patients. So whenever we're giving fluid, whether it's a bolus or whether we're administering through the pump, and while it's being administered through the pump, we're constantly checking on our patients, assessing vital signs, listening to lung sounds, ensuring we're not having that issue. Another great issue is your IV pump. It communicates with you. It tells you if there's a problem, if there's an occlusion, or if there's an administration problem. The pump is going to alarm beep beep at you and say, hey, we got a problem here. Your old school IV bag isn't going to communicate and talk to you, okay? So that's a great reason to utilize the IV pump. Another reason that the IV pump is very beneficial is because of the pressure that the IV pump exerts. So it can overcome some indwelling problems with our patient. If we have severe vasoconstriction going on, the pump has enough pressure to move past that. If we're utilizing a small IV catheter, the pump has enough pressure to get enough fluid in past that small diameter. So these are huge benefits to using the pump. So now let's do a little hands-on with the pump so I can show you how to put those fluid administrations from the protocols in. All right, let's do a nice little reminder of the IV pump here. So we're gonna do fluid administration for our patients. So you're gonna spike your bag of normal saline. You're gonna hook up your pump tubing. Remember, that's a 15 drop set. It says pump tubing right on the package, so you can't really mess that up. So spike the bag, prime the line, then I'll do a little reminder of how to load it into the pump. So to load it in the pump, we have to open the door. So it says you can open the door or press C to enter parameters. So you can enter the parameters of your drip or open the door first. It doesn't matter which way you do it. But in this case, we'll open the door first. So we hit this little button over here. It looks like an eject button. It's going to ask you, do you want to open the door? Up for yes. So it's going to open the door. Now we load the business end of the pump tubing and the pump. It can only go in one way, so you can't screw this up. There's a couple little pieces that lock in there. Then we have the green piece that slides into the green slot, nice and color coded there. And then remember, on either side of the pump, we have these nice little notches that the tubing slides into. And make sure that's in there so it doesn't interfere with the door closing. So now we can close the door. Remember, it takes a little bit of pressure to close the door, and then your pump will take over, closing the door the rest of the way. Now, the screen's going to come up and it's going to ask you a question. It's going to ask you, are you using the original space line? And yes, this is the original manufacturer's line. So we hit that little corresponding arrow next to it. Then it's going to remind you to keep the roller clamp closed while that's setting up the tubing. And then it reminds you to open the roller clamp before you connect it to the patient to administer the fluid. The next question it's going to ask you is, do you want to prime the line 25 cc's? And if you already primed the line, you got all the air bubbles out fine. If you look at your tubing and you still see that there's some air bubbles in the line, you can prime it. So let me stick the end of it in this empty saline bag here so I don't make a mess. So you can prime the line, again, up for yes, down for no, up for yes. We'll prime the line. You don't have to let it go the whole 25 cc's. Just watch your line. Once you're satisfied you got all the air bubbles out, it tells you right on the bottom of the screen, press OK to stop. So we can press OK to stop. And then we can now input the parameters of the drip. Okay, now let's input our fluid infusion parameters. Very simple. So you can see on the screen it says open door or press C to input parameters. Remember, you can load the tubing first, then put in the parameters, or vice versa. It doesn't matter. But in this instance, we'll press C to enter the parameters. Now, it's going to ask you if you want to go to the drug library. No, we don't want to go into the drug library because we're doing something separate from the drips that are in the drug library. So down for no. Now, the first screen that pops up is volume to be infused. It says VTBI. That's what that stands for. So pumps are very simple. There's a couple very important parameters we need to input. One is the volume, the specific amount that you want to infuse. The next is the flow rate expressed in milliliters per hour. And that's so once you input, the pump is so impatient. Once you input those two parameters, the pump is super smart. It does the rest of it for you. So let's think about our adult diabetic emergency protocol. On the right side of the algorithm, we need to give a 500 cc fluid bolus. Remember, we're not going to do that with the pump because it's not fast enough. And then we have to do 1 liter per hour, which will be done in the pump. So let's talk about how to put that in. So volume to be infused. 1 liter per hour is 1,000 mLs. So we want to put 1,000 mLs. So impatient. That's the idle alarm, by the way. If you leave the pump sit idle, it wants you to do something with it. If you're not going to do something with it, remember, just hold the power button down and it puts it in standby mode. So let's go over to the thousands place. We'll scroll over and then go up 1. So there we have it, 1,000, and it says mLs right under it. So we have our volume to be infused. We press OK. Then our time frame is 1 hour. Scroll down to time, press OK, and it defaults in the 1 hour spot. So we have hours, minutes, seconds. We go up 1 for 1 hour, press OK, and guess what, folks? We just programmed the pump to give 1 liter per hour. It's that simple. All right, now let's talk about the pediatrics. So for the pediatrics, we're going to press C to enter parameters. We're not going to use the drug library because we're inputting all the variables manually. So for the pediatric protocol, remember, it's 10 mLs per kilogram infused over 1 hour. So first we got to do some math. If we have a 12 kilogram patient, 12 times 10 is 120. So that's 120 mLs per hour. So we input, you impatient little pump. So we input that just like we did with the adults, but we scroll over to the hundreds place, up 1, and over to the tens place, 2. Now we have 120 mLs. That's our volume to be infused. We press OK. Then we go down to our time. We want to infuse it over 1 hour. So press OK. Up 1 hour, press OK. Now we have just programmed the pump to give 120 mLs over 1 hour. It's that simple, folks. I have the utmost in faith in you that you can program this pump to give the fluid administration that we need to give our pediatric and adult patients that are experiencing hypoglycemia. All right, folks, that's going to conclude the training. I hope you found it valuable. I hope you found it informative. I hope you like the new format. Please give us feedback. Let us know what you think. And as always, we appreciate everything that you guys do out there, and take care.